Good morning, good afternoon, and good evening to all of you. It is great to have this session together, and we'll give it a few more seconds to see if anyone else is joining. And otherwise, I'll go ahead and explain the content of our session today. So perhaps, Jayla, you can move the slide and have the one. This is, as you know, the title of our session, Addressing the Mental Health Needs of Persons Affected by NTDs. And I'll be co-moderating this session together with Dr. Julian Eaton, who is the Mental Health Director at CBM Global. My name is Wim van Brakel. I'm Medical Director at NLR. And I'm very pleased to have this opportunity to talk about, to have the three presenters this afternoon who have been leading core NTD funded studies into mental health and NTDs in the past 2 years or so. The session will be kicked off by Dr. Julian Eaton, who will give an introductory presentation. Next, we'll have Dr. Ashok Agarwal, Director of NLR India, give you some of the results of the proof of concept study for addressing mental well-being of persons affected by leprosy and with LF-related disability using a peer support intervention. We'll hear from Mr. Guillermo Robert, Technical Advisor, Global Health for Effect Hope, about a study they conducted also in India to understand the effects of enhanced self-support groups in health and mental well-being among people affected by LF. And then we'll hear from Mr. Litos Raimundo, Director of NLR Mozambique, on a study into disease management, disability, and inclusion for persons affected by LF, leprosy, and Konzo, which is you could say a local NTD that is prevalent in Mozambique. After that session, we'll have a 10-minute question and answer session. We'll have breakout groups for about half an hour, and then plenary feedback from those groups before we close the session. So without taking any further time, I would like to give the floor to you, Julian. Over to you.
Wim, thank you very much, and thank you for this opportunity to share some of the work that's been done in research in NTDs. I think it's very pertinent that it's a core NTD that has sponsored all of the programs that we're sharing today, because the work that's been done here has been so close to the ground. It's been extremely operational throughout the development of this space of intersecting between stigma, mental health and well-being, and NTDs. So I'm struggling slightly to move. Okay, thank you. So the first point really is, why are we doing this in the first place? Why is it important that we consider mental health in the work that we're doing with NTDs? First of all, anyone who has worked in this sector, especially if they've been directly engaging with people affected, will know the very high levels of the stress that people feel and the way that they're often excluded from society on the basis of NTDs, which often carry with them a lot of social baggage and stigma and myths about the causation. It has a massive impact on people's ability to engage in community, and often the things that matter most to us, our ability to be really recognized in community, to participate in community, and to be able to play the kind of roles that we'd like to within communities. There are some specific NTDs that we know have a direct effect on the brain and the nervous system, but the majority of cases we're talking really about a mechanism of social exclusion leading to this levels of distress and significantly increased prevalence of mental conditions as well. And we've learned an enormous amount about the subtleties of those relationships over the last 10 or 15 years. Importantly, as I said, we've been working very much on the ground with practitioners, and people don't just want to recognize that there's a problem, people want to be able to do something about it. And the good news is that we've been able to build a lot of the work that we've been doing off the back of previous work that's been done specifically in the space of global mental health and how we can practically approach some solutions for mental health problems that people might have, even in the most marginalized communities, in the most resource poor communities in the world. So most importantly though, when we talk with people who are themselves affected, they are the ones who say that their mental well-being is a major issue and that social exclusion is one of the things that they feel most keenly. Of course, people have physical symptoms, but it's that social exclusion that people feel very strongly, which is important because we seek to be led by the people affected. It's certainly much more of a priority now, clearly in the roadmap, and it's something that many of us would feel very strongly about. In addition to that, we're well served by global frameworks now that really put mental well-being alongside physical well-being and social well-being in, for example, the SDGs, thinking about social models of disability where participation barriers are considered to be very important to address, the right that people have to health, including mental health. And within the NTD community, particularly with NNN, that's also been recognized as an important factor. So I've mentioned some of these links already, and just to emphasize that point about social exclusion and stigma that drives many of these problems. So that has to be a place that we really focus a lot of our attention, and much of the work that's been done within the research that you're going to be hearing about has taken stigma and social exclusion as a really primary issue to be addressed. It's also worth pointing out that in some ways, mental health problems themselves are neglected tropical diseases. They are conditions that affect people in the same marginalized and excluded communities that NTDs affect people. So there's also an efficiency associated with making sure that we can try to address both of those areas at the same time. So we've made really good research progress, I would say, over the course of the 10 years or so that the Mental Wellbeing and Stigma Group at the NNN has existed, and some really remarkable work that was done before then. It's been consolidated, I think. What the main difference has been over this last 10 years is a sense of a really strong consortium of people working together. And the core NTD set of grants really came along at the perfect time to be able to energize the big research questions that were coming forward and actually start to be able to do the research that was needed to help us to translate into policy and practice. So some of that's already been incorporated into some guidelines like this mental health of people affected by NTDs document that WHO produced. And also I think the advocacy around this has helped to make sure that mental health has its proper place in global frameworks like the roadmap. We're also starting to work now towards what people on the ground really need. That's practical guidelines about what should be done that's properly evidence-based and has kind of reached the standard that, for example, WHO would expect before guidelines are produced. And we're currently developing an essential care package. Now, very importantly, the community needs to be able to access this work, and we're going to hear some of that work now, which is the first step towards making sure practitioners are able to access this research. But I'd really encourage you to, first of all, consider joining the Mental Wellbeing and Stigma Group, particularly if you're part of the NTD NGO network already, and to look on info.ntd.org, which is really the kind of the place where we bring together a lot of this research in time for people to be able to use it in the field. So that's all I have to say. I hope you enjoy listening to these presentations coming up now. Thank you.
Thank you so much, Julian. And we'll look forward now to hear from Dr. Ashok Agarwal. And I would like to encourage you to listen to these 3 upcoming presentations with the thought in mind of looking at what are the similarities, what are the differences, what are notable findings, and also what follow-up issues come to mind, follow-up questions come to mind, so that you'll be ready for that discussion later on in our breakout groups. Ashok, over to you.
Thank you, Wim. Hello, everyone. Namaskar from India. Today, I'll be presenting proof of concept of addressing mental well-being amongst persons with leprosy and lymphatic filariasis with disabilities. The study was done in Bokaro district of Jharkhand state of India. Next slide, please. The principal investigator was Professor Pesra from Banaras Hindu University, and co-investigator myself and Dr. Wim. Next slide, please. The research question which we looked into was how suitable is basic psychological support guideline-based peer support to reduce stigma and improve mental well-being and social participation among persons with leprosy or LF-related disabilities. Next. We developed the basic psychological support for persons affected by NTDs guideline. Now, this was an adaptation of the existing WHO psychological first aid, which was developed for Ebola. And Ebola being an acute condition, we adapted it for chronic situations like the NTDs. We identified and trained 13 peer supporters who were trained on the basic psychological support guideline, and then they provided support using this guideline to 75 clients. The intervention lasted for 3 months, and both before and after the intervention, we collected scores on stigma, mental well-being, depression, and participation. Next. The tools we used were SARI Stigma for collecting data on stigma experience, Warwick Edinburgh mental well-being for mental well-being data, PHQ-9 for measuring severity of symptoms of depression, and PSSS so for social and work participation. Next. I'll briefly explain what is this basic psychological support. This is a humane, supportive response to someone who is suffering and needs support. It is not professional counseling, which means that it can be done by people like peer supporters who have received some amount of training. It may involve assessing needs and concerns, helping people to address their basic needs, helping them to keep calm and comfortable, helping them connect to information services, and connecting to others, which is very important, to others, which is family, social, community, etc. Next slide, please. It is based on 3 basic principles, which actually are the principles of the WHO PFA psychological first aid, which is look, listen, and link. So look for people with urgent basic needs, then listen to them, understand their needs and concerns, and then accordingly link them. Next slide, please. We also had a psychologist. Her job was to train the peer supporters on the guideline, on the basic skills of counseling, on documentation, provide hand-holding support in the field, and establish linkages with district officials, district psychiatrists, which is very important, and government health facilities. Next. The peer supporters, each of them was responsible for 5 to 6 clients, They provided support through the look, listen, link principle. They visited the client at least once a week. They established linkages between government field workers and the clients, and provide information on various supports. Next. Now we will see the encouraging results which we got after 3 months. What we see on the slide is that the stigma decreased significantly, mental well-being increased significantly, the depression score decreased significantly. However, we did not see any change in the participation. Next slide, please. Looking in depth, what we see is that among stigma, the experienced stigma and internalized stigma, both of them decreased, but disclosure and anticipated stigma, there was no change. Next slide, please. In mental well-being, what we see is the low mental well-being decreased drastically. The average mental well-being increased significantly, and also like earlier, there was no one in high mental well-being, and now there are a number of persons. Next slide, please. Similar picture we find in depression, that the persons in severe category and moderately severe category, there was no one earlier. There were a number of people earlier, but now there is none. Next. So the conclusions which we drew from this proof of concept study of 3 months is that significant improvement of mental well-being was noticed. Significant reduction in mean stigma depression levels happened. There was no change in the level of participation of the affected persons in work and social activities. The clients are able to manage many aspects of their lives because of the 3 months intervention. However, we also felt that a lot of them, they needed vocational training and livelihood support. Next. We also had a connect with the group after the intervention, and what we are pleased to share is that the government took over the intervention in July 22nd. Next slide, please. We acknowledge the support which we have got from the district and central state and central government health officials, our collaborators, and our funders. Thank you.
Thank you so much, Dr. Ashok. And I would like to now immediately move on and give the floor to Guillermo, please.
Hello, everyone. Thank you very much. Well, I'll be presenting the 199D project, where we called UMIT internally and informally. I'll be presenting on behalf of the partnership, Lepra Society India as the main implementing agency, FedHope Canada, Lepra UK, and the Bruyere Research Institute from Canada also as technical advisors of the project. All right, next. Well, let me start with a bit of a background on how this influenced on the rationale of our project. We know LF in particular is a public health problem, mainly because of its disabling factors. And this has been embedded within one of the key pillars of LF control strategy within the global program to eliminate LF. Most recently, the Roadmap 2030 listed a number of effective interventions, but whilst these are effective, there was a specific statement mentioning that delivery may be the main challenge. In the same documents, mental well-being has been directly and indirectly addressed. And we also know for different sources about the multiple factors that influence mental distress. We know disability, stigma, and poverty may play a key role, influencing the health-seeking behaviors and ultimately the poor prognosis of the disease and so on and so forth. Well, all this basically gave us basically a hypothesis of how can self-support groups address the continuum of care and addressing all these bits whilst addressing mental health as a cross-cutting element. Next, please. All right, so MMDP, or Morbidity Management and Disability Prevention, was translated into the Accelerated Plan for Elimination of Lymphatic Filariasis in India, where improving the MDA effectiveness was a key element, of course, but also this plan aimed to improve the access to MMDP services. And that was developed in 2018, if I'm correct. And this was translated to specific MMDP policies, which are listed at the right-hand side. These were the training of health workforce around MMDP services, the provision of financial incentives for hydrocele surgeries, and the provision of self-care kits. Well, the problem, however, and this was confirmed with an exhaustive formative evaluation, indicated that there was overall an inconsistent implementation. There was barely anything happening beyond MDA. There was an overall low awareness at all levels affecting MMDP demand and health and mental health outcomes. And there was a generalized lack of trust in the already weak health systems. That altogether reinforced the initial hypothesis that MMDP activation and sustainability may strongly depend on the demand and patient mobilization at community level. So the hypothesis, next please. So the idea is, if we touch the different elements throughout the continuum of care with a self-support group model, the question is, how is this affecting on the health and mental well-being of people affected by LF? So that's really the primary research questions, to assess the comparative effect of enhancing existing MMDP services with and without community-based groups or self-support groups in the quality of life of people affected by LF. We used a cohort non-randomized study. We selected 2 districts of Bihar state, Patna and Samastipur, 4 blocks specifically in each arm. We selected 400 people affected by lymphedema in each arm. And because the training package was inconsistent across arms, we developed a training package and we standardize the training and the knowledge across arms. So we trained basically around 800 health staff in both arms with that training package. So the idea here is basically to assess the effects of enhanced support groups across arms. Next, please. All right, this is the UMIT training package. We developed 4 different videos according to the, including counseling and also the minimum healthcare package, which was about acute attack management, lymphedema management, prevention, and hydrocele surgeries, together with several documents that were validated by local stakeholders. Next, please. And here's the our self-support group model, which really included the common self-care components. These are the 4 first ones: skincare, wound care, exercise, and footwear. What we did here is basically harmonize how we did activities across the blocks in Samastipur block. Remember, this intervention was only implemented in the RMB in Samastipur district. And we added or adjusted additional components, which included counseling with a specific emphasis on family support, health-seeking behaviors, and the management of mental distress. Monitoring, we monitored self-support groups once a month, basically seeking for morbidities on how the complications evolved at individual level. And of course, we reinforced the referral mechanisms for better access to quality MMDP services. Next, please. Well, these are the baseline fundings for Patna districts. In Patna district, there was no previous intervention. And this was really a snapshot of what is really happening of the current situation. So one shocking finding was in that block, in that arm, we observed that 48% presented with mild depression using the PHQ-9 scoring system. But so that really gave us challenge or criteria of should we better use PHQ-9 alone, or should we complement that with another anxiety tool to better assess the current situation? Because as you can see at the right-hand side, people with advanced disabilities presented a far different picture. So the earlier—
One more minute, Guillermo.
Thank you. So the earlier we identify people affected, that graph may change. And you can see at the very bottom how acute attacks and the limitations at work influence the different stages of depression. Next, please. These are really the end-line findings. You can see the first one is on acute attacks. There was a big impact in the intervention arm, also in the average of healthcare expenditures. And with the PHQ-9 scoring system, we also observed that intervention B at the right-hand side, there was no difference before and after, but the score remained below 4, which was also a big difference between the intervention A and intervention B. Next, please. This is also only to illustrate the seasonality of acute attacks that may influence on the depression and mental well-being as a whole, and how we set the measurement tools. This can influence the whole project design and also how mental health is basically measured. Next, please. This is, I won't go this into details, but this is only to illustrate that the intervention also influenced on the access and satisfaction on PHC services. Next, please. Okay, finally, so the lessons learned, we really identify that combining self-support groups and health staff training together has an important effect on the health and mental health of people affected by LF, but also on the health-seeking behaviors and across the line, across the entire continuum of care. The monthly monitoring visits may be critical in initial stages. Seasonality must be considered from the very beginning, particularly at the planning stage. And determining mental distress levels at diagnosis can be complex, and there may be lots of discussions around this, perhaps during the breakout sessions. And there are plenty of scalability considerations where has the potential of including multiple diseases. We didn't have time to explore the findings around leprosy, but part of the self-support groups also included the leprosy. I'll stop here and continue discussions later in the breakout sessions. Thank you very much.
Thank you very much, Guillermo, for this comprehensive presentation. I'd like to move now to our last presenter, Litos Raimundo from Mozambique. The floor is yours, Litos.
Good day, everyone, and thank you, Wim, for this introduction. My presentation today is on the previous slide, please. My presentation today is an operational research that was implemented in northern Mozambique, and it was on disease management, disability and inclusion for persons affected by LF, leprosy, and CONS. Next, please. The research, as I said, was conducted in northern Mozambique, and it has the aim of improving disease management, disability and inclusion for persons affected by these 3 pathologies in these 2 districts of northern province of Mozambique. And the primary research questions were, what's the capacity of the Mozambican health system in general, and the NTD department at the Ministry of Health to provide disability management services for people affected by these diseases, and which strategies are currently in place to provide quality health care for persons with disability caused by leprosy, LF, and CONSO, and how are the services organized vis-a-vis other disease control programs. Next, please. We use different methods and tools because the study was a cross-sectional survey with both qualitative and quantitative data collection methods. The conceptual structure was based on the innovative care for chronic condition model, where the 3 levels of the health system were analyzed, and these are the micro level, the meso level, and the macro level. A participatory and cooperative methodology was also used in its approach, where the community was invited to actively participate in identifying and describing cases of NTDs and disabilities, emphasizing the cultural, social, and gender norms of how these diseases are viewed locally. Data collection included information about the location, which was also linked with the social demographic information. The knowledge, attitude, and practice questionnaire was used to collect data from local health professionals. Data on stigma was collected using the stigma assessment and reduction of impact. In the mental health questionnaire, we used the PHQ, the patient health questionnaire. Next slide. As I said before, it was a combination of quantitative and qualitative that were applied. Data collection tools include the interviews with semi-structured questions for individuals holding positions of leadership at national, provincial, and community levels. Data was also collected from individual interview from patients, and we also conducted focus group discussions as well as talking with guardians of some patients who were younger. We did also literature review, basically trying to compare the existing policies and strategies with what is required for disability management and inclusion services. Next slide. Next slide, please. The results were the following. 444 persons were included in the research, of which 127 suffering from leprosy, 133 of Konzo, and 184 of LF. Of 127 persons affected by leprosy, 44% were women. Over half of the persons affected by leprosy had grade 2 disability. And we note that the high proportion of persons with leprosy reported mental health, and mental distress increased when disability became worse. Those with grade 2 disability had the highest scores of mental distress. On LF, we included 184, of which 33% were female. And we also note that most persons affected by LF had mild or moderate lymphedema, 78% of them, and 16% had elephantiasis or severe hydrocele. And 66% of the persons affected experienced mental distress. The severity of lymphedema appeared to be related to high levels of distress. And mental distress was also slightly more severe on women affected by LF compared to men. Next slide, please. On Konzo, we also note that most persons affected with Konzo had moderate to moderate disability and worked with assistive devices. And 65% experienced mental distress, especially those with high levels of disability reported also high levels of mental distress. In general, we note that the existence of stigma towards persons affected by leprosy, LF, and Konzo was widely acknowledged by the patients. This is mainly caused by lack of knowledge and fear of transmission by those who care for them, including persons in health institutions, but also religious aspects played a role in this. And persons affected also by these diseases reported cases that their spouses were abandoning them, which led also to aggravation of the disability and significant negative impact on their mental health and social well-being. Next, please. So we learned some lessons during this intervention. And one of them is that there is a relationship between physical impairment and mental well-being. Persons affected by these three diseases reported high levels of mental distress when they were faced with high or severe disability grades. We also note that health services and primary health professionals are mostly prepared to treat regular diseases on a day-to-day basis, but were not prepared to render services to outpatient care among health professionals. This was lacking. Even in institutions that clearly required long-term care and mental health, patients are not guided to cope with stressors and manage their mental health. Counseling, group therapy, medical counseling, and psychiatry are non-existent in the areas where the research was conducted. And the study also reviewed the literature, and we saw that the existing policies and strategies are outdated. They are not in line with the needs of people in the place where the research was conducted. And there is limited communication between two ministries, the Ministry of Health, who basically looks for the clinical aspects, and the Ministry of Social Action, who takes care of the social aspects of people with disabilities. And we also note that delivering questions on mental health was quite very delicate and difficult, because whenever you ask them questions on mental health, patients would think that they are not mentally well. So we had to use other strategies in order to address these questions. I think this was my presentation, and thank you very much.
Well, thank you so much, Litos, and thank you all four presenters actually for staying so well within time. So I'd now like to open the floor for questions and answers to our presenters. As I mentioned, we will have the breakout rooms also shortly, where we have more room to discuss the differences and the similarities between the studies, and also any emerging lessons learned and follow-up questions. So let's use this time to ask questions of clarification or about other issues that come to mind. Who would like to take the floor? Please raise your hand if you have a question, or type it into the chat box. Beth, please go ahead.
Yeah, so I would like to know from the speakers, sort of what was the most difficult aspect of trying to get the ministries of health on board with this work?
Yeah, shall I?
Please.
It's, yeah, for everybody. It's for all of the speakers.
Okay. So thanks for that question. Actually, it wasn't too difficult to get the government on board. What was required is a clear explanation about what is the kind of intervention which we are bringing in, particularly in India. Government already recognizes that mental health is an emerging issue and it needs to be addressed, and gradually they are working on the infrastructure. In fact, there is already a plan where every district is supposed to have at least one district psychiatrist. Now the challenge was that down below, below the district, at the sub-district level, the peripheral staff, they were not oriented on mental well-being issues. So with our intervention, I think we were able to see the value of it, meaning like what can be done with involvement and support through, say, ASHA workers or A&M or the peer supporters, which we did in the study.
Thank you. Any other responses?
I can jump in if you like. Well, in our case, there was on the one hand, this is really a proof of concept, so that's easy to bring government stakeholders with letters of intent and acceptance and stuff, because they are always happy to see how concepts move forward. Another thing will be to mainstream that into the health system, which is another element to be studied in the scalability studies. But as a whole, I would say mental health has not been included in the minimum essential care healthcare package in a way. This is out of that dimension as a whole, generally speaking. So assuming MMTP service, particularly for LF, but also that applies also for leprosy to an extent. If they are not yet mainstream in the health system, it is very difficult that the mental health is also included at the PhD level. We can train them, of course, but at the end of the day, they will spend maximum 10 minutes with the patient. So that's really our hypothesis, that this element should be strengthened bottom up, and that was our hypothesis, to mobilize communities towards that end, rather than strengthening top-down approaches. Thanks. Which go in parallel.
Thank you. Yeah. Litos, you have anything to add?
Yes, I think in our case was also the same as India, and there wasn't much resistance on the side of the Ministry of Health. In fact, they welcomed, because they are in a phase of drafting their own strategy on NTD. But we find a bit of difficulties on getting the ethical approval. I think the technical part of it, the structuring of research and getting the ethical approval, that we had a bit of resistance. We also had a bit of resistance because they were hesitant that we can create demand that they cannot satisfy. If we raise an issue that the government cannot respond and bring that issue into the communities and the health units, that could create a problem of them in time that they are not prepared to respond. So these are some of the constraints that we found, but general acceptance was quite good.
Thank you, Litos. And there's a question in the chat asking, there was one presenter who noted that assessing baseline mental health was a challenge. I believe it was Litos. I would love to hear more on what you would recommend to better ascertain that data point. And I would also welcome responses from other presenters on that. Was that you, Litos, who specifically noted that? Or?
Yes, it was me who noted that. I think it's mostly on cultural aspects, and I have realized that the tools that we use, obviously they were experimented in other parts of the world, but I think it needs more adaptation in order to address the right question to the people according to their cultural perceptions of what we were asking. Most of the questions they were implying that they are mentally disturbed, they are not okay. So we had to readapt them in order to make the question right. But it's something that we are thinking of restudying and trying to have better questions addressed to more adaptable questions that are culturally and socially acceptable in the setting where we conducted the research.
Any other responses?
Perhaps I could comment on that.
We're looking at maybe. Oh, sorry. Are you able to hear me?
Yeah.
Yes, we are. Lindsay?
Okay. Thank you. We are looking at perhaps doing a similar study in Nigeria. So that's a really instructive piece of information to try to avoid having sort of leading or negative type questions in the assessment, and that it's probably culturally dependent. So maybe we can sort of test questions out before we go to the larger study. Thanks so much for that insight.
Thank you, Lindsay. Julian.
Thanks. I'm glad you were able to say something before me, Lindsay, because I didn't realize you were working in Nigeria. We were also able to benefit from one of these core NTD grants and did some work in Nigeria. And I completely agree with what Litos said about the importance of non-leading and stigmatizing questions as a way in to people thinking about their well-being. But I do think that maybe after people have been identified in that kind of original screening, it's worth doing something that can quantify a level of distress. And one of the learnings we had from our project, which included a kind of prevalence study, was that there's a very high correlation between PHQ-9, GAD-7, and the WHO Wellbeing 5, which led us to conclude that it's not necessary to do all of these things on people. You know, in terms of efficiency and simplicity, it's quite possible to identify a single measure which actually does a pretty good job of identifying levels of distress and the kind of common mental health problems that tend to arise from these conditions associated with exclusion.
Thank you, Julian. I think looking at the time that is moving forward, I'm hoping that some of the questions that are still in the chat we can address either in our groups or after the breakout groups. What I would like to ask now is that everyone, you will be assigned to a group. We've pre-assigned the group facilitators, discussion facilitators, but within each group, the facilitator will request someone to be the rapporteur who can enter the salient points coming out of the discussion on an easy retro board, the link of which will be shared in the chat, and so the rapporteurs can do that as the discussion moves along. So thank you very much indeed once again for our speakers, and you'll be seeing them again in the breakout group shortly. Thank you very much everyone for your active participation in the groups. We would now like to give the group facilitators the opportunity to give a brief flavor of what the discussion was like, and we can put the easy retro board back on the screen if that would be helpful as a reminder of what went on. I can't remember whether the groups were numbered, so I just will ask who would like to go first and present from their group, or maybe according to the sequence on my screen. Julian, you're the first.
Do you want me to present, Beth, or were you expecting to present? I wasn't sure whether it was the rapporteur or the facilitator. I don't mind. I'm quite happy to do so. That's easy. We had a good discussion, and we benefited from having Litosh with us as well. So we had a couple of people who presented. I think there was a acknowledgement of the importance of this, and how having a series of pieces of research done in this quite comprehensive way, many of them at a proof of concept level, is really taking forward a lot of research questions that have been around for a while, but we really haven't as a community got so far. But I think this has really been a kind of accelerated action to achieve that. The similarities, people talked about the importance of having mixed methods in the studies, and how we learn much more in these kind of environments from thinking quite carefully about understanding context, rather than just applying kind of international measures in a kind of routine way everywhere. But obviously quantitative work is also very important. The issue of economic measurement came up, both understanding what the impact of this work was on poverty and people's lives, but also in terms of advocacy for this work, the results to be scaled up, and that policymakers and decision makers really needed those kinds of data also to be able to make decisions. I'm trying to think what other major things came up. There was a really important point about something that did come actually from Guillermo's presentation about the impact of a mental health intervention on physical outcomes, and how that was again a justification for investing in mental health, where you could argue that there are these other advantages, as well as the kind of primary motivation of getting people better in their emotional state. I'll leave it there. I'm not sure if there's anything else that
Hmm.
Beth or anyone else in my group wanted to add.
Okay, thank you, Julian. And if we can now move to Dr. Ashok's group.
Yeah, thanks, Dr. Wim. We had a great group and a great discussion. There were discussions around the tools, like the reliability of the tools and whether the mental well-being tools could be combined. Well, we didn't have, particularly on the latter, we didn't have a clear answer, but possibly we can take it up later. We had discussions around a little more in-depth discussion on recruitment of peer supporters, recruitment of clients, and also we understood that the proof of concept which was provided, it needs to be tested further through a randomized control trial. There was an acceptance regarding that all the studies, they were community-based in similarity, and there was a relationship between disabilities and mental health. We also thought that more clarification, I mean, we were able to have a voting on the responses, and the key points, key findings, joint conclusion, the highest vote went to that clarification is needed for sampling strategies. Not all patients are affected equally. So within affected cohort, bias can be reduced by outlier patients. When lacking baseline, is difficult to randomize patients. So it's a good comment which was made. And in further consideration, I think the highest vote went to role of access to social support in elevating mental distress and facilitating mental health care. Yeah, and actually the highest was, the studies were mainly quantitative, but when it comes to mental health, it is often intertwined with religious beliefs. Participant religious beliefs could influence reporting on the scales. Yeah, so these were the major findings. Yeah. Anyone else would want to, Wim, you want to add, or anyone else?
Well, I just, for clarification on that last point, perhaps to say that what was presented during this session were the quantitative findings, but I know that at least two of the three, and perhaps Guillermo, you can comment on the study you presented also, were a mixed method study. So they also collected qualitative data, both through interviews and focus group discussions, and but they were not presented due to lack of time.
Yeah,
Guillermo?
that's correct. Yes, absolutely.
Yeah.
We invested a lot in qualitative evaluations, and yeah, definitely, there's no time in 8 minutes to disclose those.
No. Would you like to go next and talk about your group?
I think Lindsay was brave enough to.
Yes, I'm trying to be brave. We had a really interesting discussion, and it kept coming back to factors that can affect self-reporting on mental distress. It's not just phrasing of the questions, but also the external and localized cultural factors, as well as the level of disability that can affect how that's reported, which just makes it such a complex thing to address. So that was sort of something that rose to the top for me in general. And we stayed mainly in the fourth column. We had a lot of ideas for further research questions because of those challenges. And just to summarize some of those research questions, because I believe another participant already reported on our key finding and joint conclusion card that clarification needed for sampling strategies. So I'll just move to the research questions. People with disabilities have an increased risk of mental distress, and that suggests that the tools used and people sampled in the beginning may present a challenge. the earlier people are identified as patients, the fewer mental health disabilities there may be because they're not yet having physical manifestations. And the main difference between affected and non-affected groups as far as different percentages of reporting distress appeared to be in the mild distress category, not in the moderate or severe, suggesting that there may be an anxiety component that's being adequately investigated, because I understand that anxiety might be something that arises earlier than depression symptoms. The studies were mainly quantitative, but when it comes to mental health, it can be entwined with religious beliefs. That goes to the cultural factors we were discussing, and that could influence people's reporting on the scales. A gap in understanding exists between mental distress and need for care. Anxiety and depression are different, and this sort of ties into what I already stated. They may occur at different stages of physical morbidity. More specific referrals and systems are needed for patients with more complex health challenges. Gender differences exist in mental well-being and distress associated with these NTDs, and that would be really interesting to study. And finally, oh no, we have two more. What's the best model or preferred model that can address mental health while also addressing the health needs of the patient, physical health needs? So how can the tool in presentation one be embedded into community or other models? We need to explore if there's any association between education and physical therapy in these groups with mental health and improvement in morbidity. And it would also be good to look at government adoption. What leads to an intervention being enthusiastically received and adopted by the government? And that was the last point our group talked about, but I think that's so important to find out what influences government buy-in, you know, because that's sort of the goal of all of our programs, to have the, you know, host governments take these up. So thanks.
Thank you, Lindsay, and thank you again to all three groups and the facilitators and rapporteurs. Perhaps just to say, what we also found valuable is to have a sample of when the instruments are used, to have a community sample taken along, so people who are not NTD affected, because in India we ended up modifying the cutoffs that are used internationally because of quite different findings in that community sample. And so indeed, contextualizing the tools as much as possible is very important in this sort of work. I'd like to say thank you very much again to my co-moderator Julian and the three presenters, to the team from Core NTD who done an excellent job in preparing and facilitating this session, and to all of you for being with us this time. It is 2:15, and I think we're about to be moved back to the main session. So thank you very much indeed, and we look forward to the follow-up of this session, and to Joanna who will pull together our report.